So one of the interventions that most women would like to avoid, if at all possible, is to have an episiotomy or even a tear of the perineal skin. It's important to know that the recommendations for an episiotomy are really only that it should be done if the baby is in distress or if we need to give you an assisted birth using either forceps or the vacuum of Ventouse. But wherever possible, you'd like to avoid having a perineal tear. So let's look a little bit at what actually happens and when they do it. And this diagram really gives you a good indication of what I would be seeing as a midwife when your baby is born. So obviously this is your baby's head that is moved right down and is what we call crowning. So I can see a significant part of your baby's head, and that alone would be causing significant stretching of the vagina as it comes out. And this area over here is the perineum. Now, what we want to avoid is any tearing that occurs in this area, and specifically a tear that extends all the way down to your anus. And the way of avoiding it is by not purple pushing and by, wherever possible, using the birth breath that you learn in the 5 essential breathing techniques. And as I mentioned in that document, it is possible to practice using the birth breath every single day when you go to the bathroom to have a poo, because the same area, the same nerve endings are being stimulated over here when you're having a poo as when you're having a baby. The difference, of course, is that your baby is so much bigger, so that feeling and urge to bear down and push is so much bigger when it's actually your baby. If they do an episiotomy, they will usually do it at an angle to the side to avoid any inclusion of the anus at all. So it is a cut that is made in the perineal skin, either to one side here or to the other side, and then it is sutured up. Now, one of the things, and you're not going to like this at all, but one of the things that I highly recommend if you are wanting to avoid an episiotomy is to speak to the midwife and the doctor, first of all, in the last weeks of pregnancy, to make sure what her or his beliefs are in terms of whether they think an episiotomy is always necessary. And the second is that if they do think it's going to be required, for them not to use any local anesthetic. Now, the reason I say that is because when we give you local anesthetic in this area, it is literally injected into the skin directly over here, just the same place that we would do a cut. We would insert a needle in, and we would fill that area with approximately 20 milliliters, which is 4 teaspoons of local anesthetic to numb this area. And when the baby is over here and that area is already being stretched, you will already be feeling an intense burning sensation. So by inserting local anesthetic, what we're doing is we're taking away that burning sensation, but what we're also doing is we're filling up that skin. And if you had to imagine the skin of your hand, you know, this little bit over here that is really thin, the more we stretch it, the thinner it becomes. Now, I want that skin to be able to stretch enough to accommodate, I'm assuming this is my vagina, I want the skin to stretch enough to accommodate my baby to be able to pass through. If I fill this very thin, delicate skin that has been stretched out to allow my baby to pass through with 4 teaspoons of fluid, what I'm going to do is I'm going to fill the interstitial spaces, and that skin is unable to stretch anymore. So as soon as we fill the skin, it's unable to stretch anymore. And if you have an episiotomy or even a tear without any local anesthetic, it will actually be a relief because there's already a burning, stretching sensation. So any cut or tear that we give you, even without local anesthetic, would just be because we've released that stretching and that pressure and tension that is built up there. However, if we numb it, I've taken away your feedback mechanism, and I've essentially filled the tissue and the interstitial spaces up so much that they're now unable to stretch anymore, because this is almost the maximum, not quite, but the maximum amount that this skin is able to stretch. And we want to be able to allow it to stretch even more to allow the passage of the baby through the vaginal area without requiring a tear or a cut that we make. So what you'd like to do is, in the last weeks of pregnancy, first of all, find out from your care provider if it's something that they do routinely. Where I work, it is kind of accepted that if it's a first-time mum, they will do an episiotomy, which doesn't make any sense whatsoever. So I spend a lot of time working with the mums that I for the clients that I work with, just giving them and coaching them to discuss with their care provider that they have been doing exercises to prevent a tear and to work with their body and with the natural pushing urges as the baby moves down the vaginal canal. So you want to make sure that they understand that, and you can also do perineal massage techniques with your partner towards the end of pregnancy, and there is instructions of how to do this in the course. And you'll need what you want to know from your care provider is that they're going to support you and not put any pressure on you to do an episiotomy. But you want to trust them enough that in the moment, if it is required, that they'll do it, but you've already discussed it and you know that they're doing it for the right reasons and not just because that's what they usually do or that is their practice. So I've already explained about the local anesthetic, and although they say they're giving it to you just in case, once they've given it to you, it's pretty much a given that they will do an episiotomy because the skin is unable to stretch. So they're giving it to you and saying just in case, but within a minute or two, because that skin is now static, they will have to cut and release. And the other thing, of course, is that they will sometimes say, oh, it saves time, but it doesn't, because the suturing up afterwards takes at least 10 to 15 minutes. So you would rather be given those extra 10 to 15 minutes, if all is well with your baby, to just allow your baby to move down slowly and naturally and using the birth breath or even gentle acts of pushing if that feels good and natural for you. If you do end up having an episiotomy, or if there is a tear, remember that it will be sutured up with material that is self-dissolving, usually within 10 to 14 days, but it will take up to 3 weeks for everything to start feeling normal again. It's important that in the period after birth, when you are naturally bleeding anyway, that you use sanitary pads. And what you can do is you can soak some of those sanitary pads in a mixture of water with a few drops of witch hazel, and then freeze them and place them onto the perineal area for relief. That witch hazel just reduces the swelling and has antibacterial and antifungal healing properties as well. So make sure that you eat a diet high in fiber to keep your stool soft and regular, and avoid any straining in the area that is already under pressure and feeling really uncomfortable. And some mums say that it feels like they're sitting on a barbed wire fence because of the stitches that are poking into them. But as I said, they will generally dissolve on their own within 10 to 14 days. Keep the area nice and clean and dry, and make sure that after bathing or showering that you really do dry it well, and keep a clean pad and changing your pad at least every 3 to 4 hours. One of the other things that could be really helpful for healing is what we call a sitz bath, or just taking a bowl of warm water and place a handful of coarse sea salt, and to that coarse sea salt you could add lavender and other herbs, and then just sitting in that and making sure that you have a good soak, and then afterwards drying it really well, and that will aid with the healing. The benefits of an episiotomy is that it does speed up the birth process by widening the vaginal opening, but we really only want to do that if there is a medical need, if your baby is in distress, or if we need to help you with a forceps or ventouse. The risks are of infection or prolonged recovery, and if it's not sutured up well or doesn't heal well, then it can make sex after birth painful or uncomfortable, which you don't want at all. So the alternatives and the way to avoid would be perineal massage in the last weeks of pregnancy, using warm compresses while you're in the pushing stage over the perineal area, definitely using the birth breath, that will help you so much. Definitely only pushing when you have the urge to push. So even if the staff have told you that you're fully dilated and it's time to push, if you have no urge to push, then don't push. You know, being asked to push when there's no urge is the equivalent of me saying to you now, well, I want you to go to the bathroom and don't come out until you have a poo. You could be there for hours, because if there's nothing to push, it's very difficult, and that's when we do that, what happens is you end up doing what we call purple pushing and really straining, and tiring yourself out, overstraining the perineal muscles, damaging your pelvic floor, and causing distress for your baby because your baby hasn't reached the point where is time to come out yet. It's probably only a matter of a couple of millimeters, but remember that in the beginning of your labor, your baby started right at the top of your pelvis and has naturally moved down just with the contractions and the movements of the uterine muscles gently nudging the baby down. So it is just a matter of time. One of the other ways of avoiding it is not to have local injection of local anesthetic just in case, to avoid purple pushing, and to take a position that feels comfortable for you. So very often in hospital environments, it is most comfortable for the doctors and the staff to have you in a semi-reclined position because that gives them the best view and the best access to be able to help you. But that may not feel like the best position for you. You may want to be on your hands and knees, leaning forward in a forward-leaning position, and that feels more comfortable. And very often the position that feels the most comfortable is the one that aids your baby to be born in the position that your baby is in and cause the least damage to the perineum. Making sure that you use your deep breathing and the relaxation techniques, especially when you're feeling the pressure of your baby moving out. And the timing, well, you need to speak to the doctor from around about 38 weeks to make sure that they don't do routine episiotomies. Once you get into the labor room, you want to establish a relationship with the midwife who's looking after you and let her know about your wishes and make sure that she knows that you've done your bit in preparing to avoid an episiotomy so that she can also speak to the doctor and help you and guide you to make sure that you don't, and make sure that it is, if it is done, that it's only done once the baby's head is crowning or if there's fetal distress or the need for an assisted birth. So she will support you with that. So episiotomy, as far as possible, it is possible to avoid it, but you need to do the work and make sure that you have practiced the birth breath and that you work with your body's natural urges to help your baby to be born.